Welcome everyone to our session on Age is More Than a Number in Diabetes Care. My name is Dr. Tricia Santos Caviola, and I'm joined by Dr. Steve Edelman and Dr. Jeremy Pettus. We are all endocrinologists at the University of California, San Diego. And today I'm going to moderate a discussion between Dr. Edelman and Dr. Pettus on the relevance of the demographic of older people with type 2 diabetes and how do we manage priorities in caring for these patients with type 2 diabetes. So before we get started, I want to talk about a few housekeeping notes, which we have to go over. Please ensure that your webcam is activated and that you have a headset with a microphone. If you do have one, please use it because we'll have better audio quality that way. You want to make sure and silence your mobile devices that you have on you. And we really encourage you to engage in the discussion today. We encourage feedback and discussion kind of throughout the presentation. Please don't take any screenshots or photos of the material being presented today. And then we have a number here listed if you have any technical issues during the meeting. So our objectives for this presentation are to explain the clinical significance and impact of the rising prevalence and heterogeneity of patients 65 years and older with type 2 diabetes, to differentiate the pathophysiologic differences in older and younger patients with type 2, and identify the treatment implications, to prioritize considerations and construct a framework for selecting individualized glycemic targets and therapeutic approaches, and finally, to evaluate basal insulin intensification options and the consequences of overtreatment for the patients 65 years and older. And we're going to do this today by walking through some questions that I'll pose to Dr. Edelman and Dr. Pettus and really make this kind of case-based and clinically relevant. So let's get started with question number one.
All right.
Why is the older population with type 2 diabetes relevant to us as providers?
Yeah, so, first of all, thanks for having us and moderating this. It's always fun doing this with Steve. And as Trish mentioned, we're going to do this in a case-based format after we get through kind of these background demographics. And we actually have some case vignettes that we filmed for people that I think you guys are going to really enjoy. So we're looking forward to showing you those. But in terms of why the quote-unquote older population with type 2 diabetes is relevant, I mean, it's kind of a no-brainer. I think if you're in clinical practice, you're seeing, a lot of patients over 65. And of course, these patients are getting diabetes, especially type 2 diabetes, more and more frequently. So just to kind of bring these points home, I have, the first slide showing that if you look at the overall population of people with, or the age of the population, that if in blue bars is kind of the percent of people under 65 and above, the red bar is the people above 65. And this little like gold line, if you will, is the percent. And you can see that right now in 2020, about, let's say 18% of the population is above 65. But if we move to 2050, we're looking at 25% of the population that's going to be, above 65. So that's 1 out of 4 people, obviously just in the US that is above 65. So we're just seeing more and more of these people.
I love the way you said gold, like the golden years. You know what? The other thing that dawned on me, Tricia, when you're talking about treating people over 65, 65 is an arbitrary number. Mm-hmm. All of us see patients in clinic and some are 55 and they really are like 85. And others are 75 and they're spry and they're young, kind of like me. And, so we're going to get into the nitty gritty details of when to be aggressive, when not to be aggressive, when to de-intensify.
So that first slide was just to kind of make the point that the percent or the population is getting older. We know that. And then when it comes to type 2 diabetes, the first slide kind of on the left, I think is the most helpful, showing the percent of people with type 2 diabetes by these different age ranges. And you can see naturally it goes up. And particularly again, in this over 65 group, that you have over a quarter of these people now that have type 2 diabetes. So we know that people are living longer, which is a good thing, but more and more people are getting type 2. So for all the practitioners who are out there, again, I'm sure they're seeing this. And there are some special considerations for this population that we're going to get into. So we need to be aware that obviously this population exists. It's going to be more of our patients that we're seeing. And so we need to be, kind of mindful of how we're, approaching this patient population. And then again, the slide on the right that's just showing, basically the world. The more red these countries get, the more prevalent type 2 diabetes is in those different countries. And the point there is that this is more common in kind of these developed countries. Obviously here in the US, that's, we're a developed country. So we're seeing this more and more. We'd have a whole different conversation about why that is, what's happening in the developed world that's causing this. But the bottom line is folks are living longer, good thing. However, more people are prone to type 2 diabetes. So it's relevant to us because it's just what we're going to be seeing.
Right. Oh, go ahead.
I was going to say, in addition to people are living longer, they're living longer with diabetes as well.
Right. I mean, there's no question that this is a huge part of our patient population. So what are the key priorities that us as providers and patients need to be thinking about within this population?
Yeah. So, we'll go through all the, different things that we want to talk about in this patient population. But I think to kind of set this up, we actually had a video of, how these conversations can happen between a practitioner and a patient and how it's so easy for kind of priorities to be aligned. That, as providers, we're so used to, seeing these patients and it's so rote to us, we're going to add this new medication, we're going to do whatever, that we lose sight of how, new or concerning or fearful this might be to the patient. So we have just a video to show just that. So we'll play the video and we'll come back and talk about it. Hey, John, it's good to see you. How's it going today?
It's going pretty good, doctor. Thanks.
Yeah, well, listen, I got your latest lab results here, and your A1C is creeped up to a place that it's a little higher than where I'd like it to be. So it's nothing to be too concerned about, but I actually recommend starting a new medication.
What? Did he just say take a new medication? I'm trying to get off meds, not take more.
So the new medication is injectable, and it's actually really super easy to do.
Injection? Oh my gosh, I must really be sick. And that's going to hurt.
So I'll go ahead and call in the prescription to your pharmacy, and you can actually pick it up today.
I've got to get this today? I mean, how much is this going to cost? I know I won't be able to afford it.
So unless you have any questions, well, good luck, and I'll see you in 6 months.
There is no way I'm going to take this new stuff. I think I'm going to find a new doctor. Well, I'm sure you didn't recognize it, but I was John, the 75-year-old patient. I know. I don't shock you.
You don't look it. You don't look it.
No, but I think the important point is one of my personal interests in the diabetes research arena is adherence and persistence. And it is a big issue. And this is exactly what happens. A doctor comes in, wants to do the right thing. Patient says yes, he'll do everything right. And then we look at the adherence and persistence with injectables and orals, and it's just abysmal. And it's all about communication.
Yeah. And I think, highlighting that nobody did anything quote unquote wrong in this video. I was trying to do the best by you, and our priorities were just not aligned. I'm talking about your A1C, and that's kind of, in my head, and you're thinking about cost and, pain and how easy is it to take these medications. And these are all important things. So we just need to bring those into the conversation when we're talking to, especially this elderly population.
Now, I know you were acting, but you're putting a patient on a new medication. You say, good luck. Like, what's that supposed to mean? And then you say, come back in 6 months. That's a long time. Well, probably a video visit in between.
Yeah.
Well, there's no question that us as providers, we really need to take the patient into account, because clearly in that video, the provider wasn't really talking to the patient. They were kind of just in their mode, right? So let me ask you this question. Do you consider, all patients over the age of 65 to be kind of equal? Would you treat them all similarly?
No, I think the answer is no. I mean, there's a broad range. As Steve was mentioning earlier, you could have a very sick 65-year-old that, has dexterity issues or whatever it might be, or a very spry 80-year-old, So this category is helpful as a starting point that we're talking about the elderly population. But within that population, you really have to be mindful of all their other comorbidities, their insurance status, their like dexterity issues, like I mentioned, their vision, if they have caregivers at home. There's so many things to kind of like keep in mind when you're really thinking about not only what is the best therapy for this patient, but how easily are they going to be able to use it, to adopt it, to be able to stay on it, all those things.
Yeah, don't forget cognition. That some of the diabetes medications, instructions, polypharmacy condition, it's tough. And then, unfortunately, there are other conditions that may shorten their life expectancy. And that really relates to how tightly you're going to control them. I know we're going to get into the A1C issue. So, when you think about it, we've had this field called geriatrics for centuries, or at least decades, when I was in training. So it is a form of geriatric medicine. And we just have to be cognizant more as non-geriatric trained physicians to be aware of these issues.
Now, Steve, you kind of mentioned the A1C, and I want to ask you guys to dive into that a little bit deeper. How, are the A1C goals the same for everyone over age 65?
Go ahead.
How do you come up with a target for a patient?
Well, you know what? We've used A1C for a long time. It's the gold standard for, looking at the risk of developing complications. And we know that there are many issues that can make the A1C inaccurate, especially in the elderly. So chronic kidney disease, anemia, liver disease, and a lot of other issues that can occur that can affect the CBC level. So, it's something that we can't hang our hat on. Now, on the other hand, it is our gold standard. We still need to order it, even though continuous glucose monitoring is coming. It's certainly less accessible to type 2s than type 1s, and we use time and range. But that may be for those individual patients that can get a CGM, and that does help give us more information about the ups and downs. And the A1C does not say anything about hypoglycemia.
Right. And I think that's such an important concept, especially in this population, because as providers, we're always thinking about that perfect A1C target that we want to get someone to. And in this population, we have to shift a little bit and think about safety as well. And is there an A1C that may be too good for a patient of this population?
Yeah, I think you're right. It's just the shift of priorities. And I think this is a slide that kind of helps give us, some specific guidelines on actual A1C targets. Because you're right, we always think A1C less than 7. And we can kind of get just blindly just always have that in our head. But we have to remember, what is the point of getting an A1C less than 7? And the idea is that if you keep people there, you can avoid long-term complications. Well, if you have somebody that's 85 and, with a lot of serious health conditions that may only live, unfortunately, for a couple more years, we don't need to be so stringent with glycemic goals. In fact, we need to be a little bit lax to avoid hypoglycemia. So it shifts away from kind of long-term benefit to more, what are the things that could be potentially harmful in the short term with falls or hypoglycemia or these other things. And so this just puts us into numbers. That if you start on the left part of the slide, that we're looking at someone with very poor health, maybe they have, malignancies or whatever it may be, that their life expectancy is short. There's no real benefits to tight glycemic control in that patient population. So you don't want to just let go of everything and have their blood sugars go really high, but controlling them into a reasonable degree and with complete avoidance of hyperglycemia. And then in the middle, you have somebody with kind of intermediate health, and there's some examples of what that might be, where we try to keep their A1C less than 8. Now, also keep in mind that just because you let somebody's A1C kind of float up, if you will, to around 8, that doesn't mean they're immune to hypoglycemia. So you still have to be mindful of that. Even if somebody has an A1C of 9, they still might be having lots of lows depending on what kind of regimen you have them on. And then finally on the far right is maybe the group that we're more used to talking about is, okay, long-term, health is okay. Let's be mindful, try to get their A1C down to less than 7. So again, even if you aren't beholden to these numbers, the concept is very important here, that you want to kind of assess the overall health when you're especially dealing with this over 65 population.
Yeah, I'd like to add though, we don't want to let patients go sweet, because once your blood sugars start creeping above 200 consistently, your immune system is affected and higher incidence of infections, bed sores, and there's some data to show higher incidence of falls. So there are such things as the acute complications of diabetes. And if they don't have access to free water, they can go into hyperosmolar non-ketotic coma. So I totally agree with this concept, but my own personal preference is people should be 8% or below.
And I think the other caveat to that is, let's say you do have somebody with poor health and their A1C is 6.8. Well, if they're on a regimen that has no hypoglycemia and they're doing, fantastic, there's nothing wrong with that. You don't need to automatically just say, I want to have your A1C higher. It just, again, is this concept of weighing all the pros and cons of the different treatment options and your overall goals.
Right. And I think, we're moving more and more in this direction in the diabetes world to individualize care. And I think what I'm hearing you guys say is that it's just even more important in this population that we take kind of other bigger things into account besides that. And we really hone in on individualizing what's important for each patient.
Yeah. And last comment is that we've studied that there's a lot of asymptomatic nocturnal hypoglycemia in the elderly. and they have to get up at night to urinate, and it could be a definite cause of falls, fractured hip. And then, as you know, once you get a fractured hip when you're elderly, it's not a good thing.
Mm-hmm.
Well, let's move on and get into the nitty-gritty of how we're going to actually manage these patients now that you've given us kind of the bird's eye view. So how do you approach intensifying therapy within this population, particularly when moving to injectables?
Yeah, so
Carefully.
Yeah, I think
Please.
no, that's really the way to say it is because this is an area that it takes some time, some education. It's something that we know is delayed for generally too long, especially maybe in this patient population where like there's an avoidance of wanting to start new therapies. So if you have a patient that's on orals and it's time to start an injection, that requires some tact and a system set up in your clinic so that you can actually do it. Because what happens, a patient says my A1C is whatever 8.5, give me 3 more months, give me 6 more months, and suddenly that's 7 years later. So developing ways to have this conversation, and as an excellent example of it, we brought John, who you may recognize again, back to our clinic to show a way that you could potentially have this conversation. John, how's it going?
Good, doctor. How you doing?
I'm actually doing well. It's good to see you, but what can I do for you?
Yeah, I'm a little concerned. My A1C is a little high, and I'm on a ton of pills, and I'm doing the best I can with my diet and exercise program.
Yeah, I get it. That must be so frustrating. And it's actually a very common problem. And the reason it's common is that type 2 diabetes is actually a progressive disease, which means that over time it can be harder to control your blood sugars, and we actually have to add medications. But importantly, it doesn't mean that you're failing. I'm sure you feel like that.
I do. I really do.
So, we got to do what we got to do to keep your blood sugars under control so you live a long and healthy life. And, looking at your chart, it is time to add another therapy. And the thing that I would actually recommend for you is a once-a-day injection. So how do you feel about possibly doing an injection?
Well, I don't feel that great, but I'm willing to go with what you suggest.
Well, thank you for your honesty, and I get that. So what I would like to actually do is actually show you an injection in clinic today, show you how to do it, what the needle looks like, and honestly, these needles are almost painless. And, after a month or two, if you're on it and you don't get the results you like, we can always change.
Okay, well, that sounds good.
And the last thing I want to bring up is, cost. So this is something covered by most insurances, and there's copay cards that can help with, getting your copay down. But importantly, if it's not covered or something doesn't work right, just let us know and we can, help you out with that.
I really appreciate that part.
Well, you know what? I'm going to, start working on this and we'll get you started, but I'll be right back, okay?
Really appreciate it, doctor.
All right. Good seeing you. So I hope you enjoyed it. And, we just kind of wanted to summarize some points there. So first that, again, this isn't like the end all be all the way to do this. This is an example. And it didn't take that much time. You're watching this video. It took a couple minutes. And some key things within that discussion was one, I did bring up the pathophysiology of type 2 diabetes a little bit. And not to get into insulin does this and insulin resistance and you need charts or whatever. But the pathophysiology in the sense that this is a progressive disease and it's not necessarily the patient's fault.
Yes.
That we're adding therapies. This is the way that the disease goes, not that you're necessarily failing.
I think that's such an important point when we're talking about injectables.
Yeah.
Because patients tend to feel like injectables, maybe they failed or they haven't done something right or there's a stigma around them. So I think that's such an important point that you bring up.
Yeah.
And for our sophisticated audience here, insulin resistance is one of the sine qua non pathophysiologic defects, and the body has compensation in the early stages of secreting more endogenous insulin to overcome that. But over time, the longer you have diabetes, the insulin secretory ability goes down, the insulin resistance doesn't change. And that's why eventually many patients will need insulin to help manage their diabetes.
Yeah. Even if they're doing everything right,
exactly.
Which is an important point.
Thank you.
So another thing is to ask questions. And I think there's a fear, a little bit of a fear from the provider side that if you ask a question, it's going to open up a door and take a lot of time, whatever. But especially when you're starting injectable therapy, it's really important to gauge somebody's views of that. Is this something that is anywhere within your realm of doing? And sometimes people say there's no way in heck I'm going to do that. And other people say I have no problem. So figuring out where they are, and then you can kind of have a conversation to get them to hopefully come on board with it. And the last thing to help with that is always trying to get them to do the injection the first time in the clinic. Showing them what it looks like, if it's a pen, how to put on the pen needle, a syringe, how to use that. And then, along with that, how generally like painless it is. And I can tell you that it's the very, very, very rare patient that once you go through all this and show them how to do it, that they still say no, or they don't want to do it. I don't know.
No, I was going to add that, Jeremy. We obviously didn't have time in the video, but to spend a little extra time on the first injection. And, in clinic, these guys know I used to ask the fellow or the resident to pull up their shirt. I'd take a clean needle and I'd show them, using the dart effect. But Jeremy's right. You get a patient, you do their first injection. Even if you're not going to start the medication that day, just get a needle, put it on a pen or a syringe and with nothing in it, obviously. And once they get an injection, they go, that's it. It's really that first injection. So it's worth the extra time.
And I'd say, that we're fortunate that we have educators that we can have do this. But even if you don't, there's all kinds of online videos that you can show people to do. I mean, again, nothing really takes the place of in clinic, but showing them, ways that they can access this information is really helpful. You can actually do it yourself too, as the provider, getting demo pens. This is something that reps can give you, getting, needles. And again, it doesn't take that much time. And in my personal, experience, it greatly increases the chance that people will start it and potentially, continue on it.
And what you said to that patient,
who was
that was me.
Yeah.
If it doesn't work and if you don't like it after several weeks, we could stop it. And many patients have that feeling like once I start a medication, I could never get off it. And that might be true when it comes to insulin, but nonetheless, it put that patient at ease.
Yeah.
All right. So we've talked a lot about how the pathophysiology of this disease is progressive. And so patients, when the providers out there are seeing patients, they can be kind of anywhere along this spectrum of disease. So what I want to do is go through a few cases and see kind of how you would approach them in an older population. So let's take a first case of a patient who actually has an A1C at goal in their target range, who's on metformin and a sulfonylurea, but they're having hypoglycemia. So what is your approach to that patient? Because we've talked a lot about safety.
Yeah. Well, I think, first of all, like you said, let's say their A1C is at goal, it's 6.8 or whatever. It would be so easy for a provider, especially you're a busy primary care provider, to just not even address diabetes if they've got other things going on. So recognizing that here's a patient that's elderly and they're on a therapy, sulfonylurea, that can cause a lot of hypoglycemia. So really, we're trying not to use sulfonylureas at all in type 2 diabetes unless there's like a real cost issue. But particularly in this elderly population, it's something that we really try to eliminate. Because there's so many better options now that you don't really have to use them. They can definitely make people prone to hypoglycemia. And again, in this population, potentially falls and all kinds of things. So first thing I would do is absolutely get them off the sulfonylurea. And depending on their A1C, maybe you could just do that. If you needed to replace it, a DPP-4 would be a great option. No hypoglycemia. SGLT2s would be a great option. So just again, being aware of it, identifying sulfonylureas, like you're just like, alarm should go off in your head anytime you see that for pretty much any patient, just like, do I need this? But particularly for the elderly. Yeah,
really, really good points, Jeremy. I would say this, if a patient's complaining of daytime hypoglycemia, you can only imagine what's happening at night. And the second thing I'd like to say is that I've seen many times in clinic where a primary care doctor stops a medication because the A1C is good, they stop the sulfonylurea, and then the patient, they have patient come back in 3-4 months, the A1C's 9-10%. So these sulfonylureas, they work. And I would say if you're going to stop one completely, please keep a close eye on the patient because they will drift up pretty quickly.
So for this first case, just, I think what you're saying too is remember that those A1C targets that we were talking about in this population, where their target really needs to be individualized and there's such thing as too good, right? Which is kind of a new concept. All right. What about, let's do another case where you have a patient who is on oral medications only. Their A1C is above their goal. And so it's time to add their first injectable. And maybe, kind of to set us up for that, can you walk us through the different injectable options, including insulin, GLP-1 receptor agonists, and fixed ratio combinations?
Yeah. So this was, I guess pretty much the case that we just had. Let's say metformin, DP4, SA2, and they're still not where you want them to be. What are your options? Well, you really have those three categories. You have, basal insulin, a GLP-1, and this fixed ratio combination, which is a GLP-1 and a basal insulin together in one injection. And they're all good options, but we're really trying to move away from basal insulin as your first injectable, because it has hypoglycemia, it has weight gain. We just have better options. So it really puts you in the, should I use a GLP-1, and we have daily, we have weekly, or should I use a fixed ratio combination? And again, these are both really, really good options that give you potent A1C reductions. Certainly with the GLP-1 alone, less or no hypoglycememia. So just for people to be aware of this, that this is something that we've been doing for a while in endocrinology, moving away from basal injections, but it still seems to be kind of what people are reaching for first. And it's been a change in the paradigm.
Well, the only caveat I'll say is that if you look at the guidelines, if the A1C is 2 percentage points above the goal, then insulin is definitely recommended as a good choice. Gets rid of glucose toxicity, gets you off on the right foot, and then you can potentially switch to a fixed ratio combination.
Yeah, that's true. And especially anytime somebody has symptoms of hyperglycemia, I don't want people thinking like never insulin. But, I was kind of imagining a case that the A1C is just a little high, but you're absolutely right.
But I think what you're talking about, again, is individualizing for this population, where maybe someone who was younger, where insulin was a little bit safer, you may jump to it a little sooner. Whereas in this population, you're really going back to kind of safety and easeability and other factors.
Mm-hmm. Yeah, the first injectable is important. And I think, the options you mentioned are all good, but it just depends on, I shouldn't use the word depends when we talk about elderly individuals, but it does depend.
We'll show some data a little bit later on the fixed ratio combinations, again, how this can be a really good option, potentially increasing compliance, reducing complexity of the regimen and stuff. So we'll come back to that a little bit later.
Yeah, the complexity is key.
Yes.
Mm-hmm. You can't just put someone on basal bolus and say, come on back in 6 months and good luck.
Mm-hmm.
Well, speaking of complexity, the last case that I want to run through with you both is a patient who has an A1C above target, who's on oral medications and is already on basal insulin once a day, but they need more. And I think this is maybe the scariest scenario that providers kind of find themselves in, where, normally maybe they may add one thing or another, but in this population, it can get very complex, for example, to add prandial insulin. So tell me how you would approach that.
Well, this is a very good example of a patient who could do very well on a fixed ratio combination. I mean, I like the fact that it's one shot a day. And I tell my patients that, we're adding a little bit of this GLP-1 drug with the basal insulin. And it's amazing how much more effective it makes the basal insulin.
Basal insulin that they're already on, it's still one injection.
Well, from a patient perspective, they may not even feel like they're changing much, right? Because it's still just one injection a day. It doesn't feel like you've added another medication.
Right. Yeah, and we're going to review some data that will show you, some benefits of that compound. Now, the other thing too is you could add a GLP-1.
Yeah.
And, you do have the complexity a little bit, but with the fixed ratio combination, because you start with a certain dose, even if the patient's already on basal, you titrate super slowly.
Mm-hmm.
Now tell me, the third option here is adding rapid acting insulin.
Yeah. Providers, we don't like it because of hypoglycemia, weight gain, and it takes time to do it right. Patients don't like it because who wants to take another injection before every meal? So, a lot of patients will ultimately need it, but it's certainly not something we want to, kind of jump to right away. It's complex. It's all those things. So when you have somebody that's already on basal insulin, trying to get the most you can is certainly adding a GLP-1, whether that's alone or in a fixed ratio combination, absolutely first way to go. And then if you have to down the line add, a mealtime insulin, you can.
Yeah, we want to be fair and balanced too. There are situations where a patient's post-dinner blood sugar goes through the roof, but they seem to do very well the rest of the time. You could add a fast-acting insulin once a day. Mm-hmm. You can do inhaled insulin if you want. So there are options. There's no one set way. But I think for the masses, you're right, Jeremy, bolus insulin before meals is just not setting up the patient for success.
That is worth mentioning, though, that if you are going to go to mealtime therapy, that starting with just with dinner usually is the way to go. Because going from, let's say, one injection of basal to now all of a sudden you have to do, 3 a day can be overwhelming to patients. There's a lot of data that just targeting that largest meal can sometimes do just as well. So if you are going to do that, that's a little bit of a, a lesser hill to climb with just starting with one injection.
Well, what's interesting is that even though the dinner meal is the biggest meal, as you know, Trish, that even though the breakfast meal may not be as big, the post-breakfast rise is higher than other times of the day, which sort of goes along with the recommendations for these fixed ratio combinations to be taken first thing in the morning, because the GLP-1 component to these fixed ratio combinations can improve postprandial. Mm-hmm. So it's, we typically do dinner because we think it's the biggest meal, but before breakfast, because there's a whole pathophysiology that people usually bounce up higher after their morning meal.
And I think what I'm hearing you say is you're also commenting about factors that we've already talked about with older adults, such as complexity. If they need help with their medication from a family member, to have someone there 3 times a day to give an injection is complex versus somebody who can stop by in the morning and give an injection. So, you're really bringing in those other things you were talking about early on.
Yeah. That's so important, what you just said.
All right, let's move on to our last question. How can we approach de-escalation of therapy from basal bolus? And I want to talk a little bit about this term de-escalation. It feels a little weird as a provider, but again, we're kind of shifting the way that we're thinking in really determining what's safest and best for this population. So how do you think about that?
You go first, Jeremy, because we were talking before we started. What does this word de-escalation mean? It's kind of a weird concept for diabetes management, because we always are taught to add, not subtract, or even exchange.
Right.
Well, I think, it's important. And then just to have this conversation with patients, you have to let them know what you're doing or what you're thinking. You're on this complex regimen. I'm worried about hypoglycemia. I still want to keep your blood sugars in a safe place, but maybe we can get there in a less complicated way. Asking what their concerns are with their medications. Is it cost? Is it complexity? Is it hypoglycemia? Whatever. And so I agree that this de-escalation is a little bit of an odd word when we're really talking about what's the best way to get this person, in a safe, healthy place. And sometimes that might mean taking away therapies and de-escalating. Other times it might just mean changing. So it depends.
And the other important point is we've been telling our patients to keep their A1C down their whole lives, right? And sometimes when you de-escalate, the A1C may creep up a little bit, still in a safe range. And that takes a conversation.
Absolutely.
That you're not going to die of diabetic complications. And, taking people backwards sometimes can be difficult. I don't care what age they are.
It is. And, I can think of a lot of patients that I've had that it is, they've had it beaten into them too, yes. That I need my A1C, wherever. And if it's 7.5, 7.6, they might be really upset about that. And so again, it's an explanation and reminding that we're not just going for this magical number that all of a sudden makes something better. It's about, what are our goals? And maybe having you right at 7.5 with no hypoglycemia, maybe that's a sweet spot for you. But you got to explain it rather than you don't need this anymore, kind of situation.
Well, you guys made a video about this one too.
We made a video about this too.
You're going to like this one.
So this is, now going to be kind of a back-to-back way, potentially the wrong way of having this conversation, and then kind of maybe a more appropriate way. And so we want to make sure that, again, we're having fun with this idea when we show it the wrong way, to contrast that with how you can have this conversation in a more appropriate way. Enjoy. Hey, John, sorry I'm late. My tea time got pushed back, and then the door in my Lambo is stuck. So you know how it goes. So anyways, how are you doing today?
Well, I'm a little concerned about my A1C. It's 8.2% now, and I'd like to talk about how we can get that lower.
8.2%. And how old are you again?
75.
Getting up there, aren't you? I wouldn't be too concerned with your A1C. I mean, it's probably hard for you to remember to take all those medications anyways, am I right?
No, not really.
Yeah, that's what I thought. So why don't you go ahead and just, enjoy the twilight of your life, and I'll see you again in 6 months. Hey, John, how's it going?
It's going pretty good, doctor. How are you?
I'm doing well. Thanks for asking. It's good to see you. And so, what can I do for you today?
Yeah, I'm a little concerned about my A1C. It's a little high, and my regimen is so complicated, so many injections per day.
Yeah, that makes a lot of sense to me, actually. And, remind me, how old are you again?
I'm 75 now.
Yeah, but you still got a long life ahead of you. And the thing is, as people with diabetes get older, our priorities shift a little bit. Of course, we want to keep your blood sugars down, but we also want to make sure to avoid low blood sugars, what we call hypoglycemia, and make your regimen as uncomplicated as possible. So tell me, are you having a lot of low blood sugars?
I do have 2 or 3 a week and at any time during the day, so that's a little frustrating.
Yeah, and that concerns me. So there are some new options, and we could potentially get you on 1 injection a day. So get rid of all those mealtime injections, keep your blood sugars in check with less hypoglycemia. So would that be of interest to you?
That sounds really good.
That's awesome. So I can actually prescribe this for you now, and then we can spend some time talking about how we would actually start it and titrate it.
That sounds good.
All right, let's do it.
Okay.
All right, so hope you guys enjoyed that. So for the first video, which was kind of the wrong way to do this, we really kind of took liberties with exaggerating the situation, where I was a complete jerk, to be honest, and I'm sorry about that. But the point there is that mentality is real, that sometimes providers can see just, a number of their age. Oh, I'm going to go see this person. They're 75, they're 80, whatever. I'm just going to kind of be slightly laissez-faire about things. And if their A1C is X or they have this degree of hypoglycemia, I'm just not really going to address it. So it goes back to our initial points where it really depends on the patient. And yes, Steve was, playing this elderly patient, but very, spry, obviously not having issues taking his medications. It was very, very wrong of that provider to just kind of blow this off. And that we still need to actively engage with people with diabetes. Even if that does mean de-escalation, it's still an active engagement around diabetes.
Yeah, his regimen with multiple mealtime injections put him at risk for hypo. So even though he seemed like a pretty adherent patient, he was still having issues with his regimen. I thought you were very nice.
Oh, and the second one.
Yeah, the second one.
Yeah.
Oh, well, we're talking about the first one. Yeah.
One thing that struck me about the second video was when you, the patient, mentioned how complex it was to take all these injections.
Mm-hmm.
And, there are some patients that say that. There's a lot of patients that don't say that. And they don't mention the fact that maybe they're skipping their injections a couple of times a day because it's just too much.
Right.
And I think that really brings us to talking about, sometimes we may need to de-escalate simply because something is too complex, right? And so, and I think talking about kind of the fixed ratio combinations and versus basal bolus therapy is really where we can see that complexity come in, and maybe there's a benefit.
Yeah. You're so right, because I think so often once someone on basal bolus, we kind of just assume they're going to be on it forever.
Mm-hmm.
That's the end of the road. That's what they have to be on. I'm not even going to think about it because that's the last step of our paradigm. But now we have options to potentially get people off of bolus insulin, which is, so huge.
Yeah.
Right.
But Tricia, what you said is extremely important about patients won't come out and say, I'm not taking my medication. In fact, if you ask them, they might say, yeah, I'm taking my medication. And, I find it's the rare person with type 2, and I'll stand behind this, that is totally adherent to a basal bolus regimen. And mainly because it's not really their fault. There's no sense of urgency. They skip an injection when they go out to lunch or dinner, and they don't feel that different.
Yeah.
If you're a type 1, you're going to feel pretty bad when your blood sugar is 400,
Mm-hmm.
skipping your mealtime insulin, but it's totally different in type 2s. And I think that's a big issue.
It's
a really
is.
big issue.
We actually have a slide up here with some data from a study looking just at this. You want to walk us through this, Steve?
Yeah, this is actually part of the data set of an abstract that was presented at the American Diabetes Association meetings. This was a retrospective review of administrative claims database of patients who were on basal insulin for a year, and then they were treated with either a fixed ratio combination or a basal bolus regimen. Basal insulin plus fast acting with each meal. And at the end of a year, it was a clear advantage with the fixed ratio combination, better adherence. They're filling their prescriptions and taking their medication, better persistence, continuing the medication over the entire year. And the other thing too is they had less resource utilization in terms of hospitalization, less hypoglycemia. And one thing I loved was they didn't have any weight gain compared to the basal bolus. And that's what you'd expect.
Yeah.
Now, just to let you know, the A1C difference was a little greater in the basal bolus regimen. It was like 0.8 drop versus 0.6. Don't quote me on the exact number. And And I think that relates to our conversation about de-intensifying. That patient's A1C may go up 0.2%, but their regimen is safer and easier.
Yeah, and I think, the specific numbers from that was there was 4 times greater adherence in the overall fixed ratio combination population, and when even better results in the elderly population. And as you always say, these things don't work if you don't take them. And it seems like such an easy, duh kind of thing to say, but it's really shocking, the amount of people that stop taking medications or never felt it, whatever. It's probably the main problem in type 2 diabetes. The reasons for it are multifactorial, but it comes down to us as for providers to come up with the easiest regimen people can take that works for them, that's safe, et cetera.
And I think the important thing about this study is that data persisted in the population of older adults that we're talking about here, which, some people may think, gosh, if you change their regimen after a certain number of years or something, it's going to be more confusing. But it turns out that making things more simple may make it easier for them to take their medication.
Yeah, you're looking at the data in patients over 65. In this study, they took a lot of people who just had type 2, not less than 65, and the data is parallel.
Yeah.
So, I mean, I know we've been talking about the elderly, but I don't think there's a type 2 patient alive that wouldn't enjoy being on a simple, effective, safe regimen. So I know we talk about that. The other thing I want to say is, when fixed ratio combinations came out, everyone kept saying, oh, it's a perfect drug for primary care doctors. Well, you know what? It's a great drug for endocrinologists as well. And so it's not just a primary care doctor, patient.
Jeremy, do you want to walk us through some of the other data that came out of this?
Yeah, so this is another study called the Beyond study that was actually just published in Diabetes Care. I really like this study, actually. So they took patients, exactly kind of the patients that we're talking about, type 2 diabetes, on basal bolus, around 300 patients, and they asked the question, how would people do if we randomize them to either continue kind of intensifying. Yeah, so they could continue on basal bolus, or they could be switched to a fixed ratio combination, or they could do basal insulin plus an SGLT2 inhibitor. So again, the question there is, how much gain do we get out of just continuing to try to work with bolus insulin versus potentially doing some of these switches, which I think is a really, really good question. And the data that I'm showing here is actually just the data versus basal bolus versus the fixed ratio combination. And you can see across the board that the fixed ratio combination does really, really well. That you go from like 62 units a day on basal bolus versus 27 units per day on the fixed ratio combination. And what I found was really interesting that at baseline, the amount of bolus insulin these people were on was about 25 units a day or so. So people always say like, well, how much is a GLP-1 addition worth in terms of like how much can I pull back? And here we saw if people were on like 25 units a day or so, let's say 8 units per meal, you can get rid of that completely. So maybe if somebody's on 50 units per meal, like it won't work. But if they're on like kind of this intermediate amount of insulin, you could potentially get rid of it.
Yeah.
So they use less insulin, lower rates of hypoglycemia. You can see in the different bar graphs. Obviously, fewer daily injections, an average of 4, injections per day, which makes sense. A basal plus 1 with each meal, versus just 1 shot a day for the fixed ratio combination. And you see it there in graphic form. It's 4 versus 1. Like, it looks really impressive, but that makes a big deal, like difference. And it's worth just showing that in graphical form. That it's 1 injection. Also, practically speaking, 1 copay,
Right.
Cost is something that we did bring up in the videos, but it's important for people to kind of have that conversation with their provider. And then of course, with weight gain, you're going to gain weight if you add more insulin, and with the fixed ratio combination, people are losing weight. So these kind of, to me, hit the things that we want in a therapy. Where the A1Cs I didn't mention, where there was no, difference between the A1Cs, which is obviously important, but with less insulin, less injections, less hypoglycemia, and actually losing weight, it makes a lot of sense. And it's just on us as providers to recognize this opportunity. That if somebody's not on a GLP-1, sure, you can add it as, a standalone, but you can also just add it as a fixed ratio combination with the basal insulin in 1 injection as a potential option.
One thing, there's a lot more studies than the several we've showed you, and the data is very consistent. So it's not like, some studies show that, it doesn't help. Some studies show that it does, but it's a very consistent database.
Mm-hmm.
And I also just, what you two have said, that many times in a busy practice, healthcare professionals don't have time to ask, Is your regimen too complicated? Are you able to take your medication as we've talked about? And if you don't ask that, you're missing a lot of poorly adherent patients, not because they're bad patients. They just have a hard time keeping up with the suggestions that you've made.
Yeah.
One thing I want to hone in on this data is, we talked a lot in the last hour on safety and complexity in this population, but every time we're adding a new medication to older adults and they end up with polypharmacy, we're adding the potential for additional adverse effects. So, Steve, can you comment on, we talked a little bit about the data here, but can you comment on how using a GLP-1 and basal insulin in a fixed ratio combination can actually mitigate the side effects of both of those medications together?
Yes, great question, Tricia. Well, we know that, first of all, GLP-1s they've made a huge mark on diabetes, especially in the last 5 to 6 years. And there's no question that they are impressive class, but they can cause complications. They can cause GI side effects, nausea, vomiting, even some other GI effects. And we know that with a fixed ratio combination, the dose is titrated as if you were using basal insulin, 1 unit at a time. Some patients 2, but primarily 1.
That's so important to say because people are familiar with dosing basal insulin, and you're dosing it the same way. Mm-hmm. You're dosing it based on units of insulin, and then you have the GLP-1 component that's part of it.
Yeah, appreciate that. And also, insulin, although, we've tended to avoid insulin in the last couple of years for the obvious reasons, but basal insulin can go a long way getting a patient under control. And you add a GLP-1 to a basal insulin, and I told one of my patients, it's like basal insulin on steroids. It's not the best example because steroids raise your blood sugar, right? But it's amazing what a little bit of GLP-1 does to basal insulin. We've seen that in so many cases where someone was on basal insulin, a fairly good dose, and then switched to a fixed ratio combination where you wouldn't think that the maximum basal rate for that particular formulation was not going to do it. And it does. It does in terms of their control. So, you know what? I'll say it again. It's a great drug for primary care doctors to use. It's a great drug for endocrinologists to use. Mm-hmm.
Yeah. And I think, less GI side effects, less weight gain, less hypoglycemia, which we've touched on several times as a major problem with this population, are definitely benefits. Well, you've certainly, I think, covered a lot with this population of older adults and really hit home on kind of the main points that we're trying to, prioritize as providers. Do you want to leave us with any parting thoughts on kind of takeaways for our providers on how to treat older adults with type 2 diabetes?
I think just having a greater level of awareness, being patient, we need to be patient with the elderly, and it may take more than one explanation to make sure they get it. So be patient, walk them through things, see them more frequently than every 6 months. And you know what? Try to reach out to their caretakers. Ask them to come to the visit. What I do personally, I record my visit on their smartphone if they have one. A lot of times we don't have that, and they can take it home and listen to it later. So it's just treat them like you would treat your grandparents.
Yeah, I would just say, there's so much going on in type 2 diabetes with all these different options, which is a good thing, but it can be difficult to keep up with. So just continue to educating yourself as a provider, and honestly, good for all of you watching this that you're motivated and interesting and finding out new ways to take care of your patients. And if you implement these things, you can get good results and, potentially better patient care. So it's just an exciting time, honestly, to be treating people with type 2 diabetes, and especially with the elderly population, which we know is getting more and more prominent, to use these tools.
When Jeremy gets over 65, I'm going to help take care of him. Any parting thoughts on that?
No, I mean, I agree with you both. And I think just remembering that it's okay, when we think about this, how this disease progresses and how our older adults are different than our other patients, thinking about things like simplicity, thinking about things like, avoiding hypoglycemia and A1C targets are really just important to consider when treating these patients. So thank you both for a great discussion. I hope everyone learned a lot, and we'll see you at the live Q&A.